Hello, it's a pleasure to be able to present this talk today. Thank you for the organizers for inviting me. I'm going to talk about physiologically difficult airway today. The objectives are to outline the burden of physiologically as opposed to anatomically difficult airway in critically ill patients, recognize patients and risk, and to be able to prepare and mitigate the consequences and review some expert recommendations. I do have some financial relationship, but they're not pertinent to this talk. So recent multicenter study was done in almost 30 countries with 200 hospitals and almost 3,000 patients. The reasons for intubation of these critical ill patients were respiratory failure and 50%, followed by neurological impairment and cardiovascular instability. And as you can see here, the burden of physiologically difficult airway is high. Cardiovascular instability was noted in up to 43% of the patients. So almost every other patient had cardiovascular instability during and after intubation. Cardiac arrest was noted in 3% of the patients, severe hypoxemia in 10%, new onset cardiac arrhythmia in 6%, and aspiration of gastric content in 4% of the patients. As you would expect, patients who did have either severe hypoxemia or cardiovascular instability in peri-intubation period had worse clinical outcomes. At the Mayo Clinic, we also reviewed our practice on about 2,600 patients with ICU and hospital mortality a little better than in the international study, but still high. And again, cardiac arrest anytime post-intubation was noticed in 4% of the patients, sustained cardiovascular collapse in 20% of the patients, and sustained severe hypoxia in 7% of the patients. So the concept of physiologically difficult airway is relatively new. It's characterized by physiological alterations that place the patient at an increased risk of cardiovascular collapse and other complications during and intubation and transition to positive pressure ventilation. Physiologic derangements do occur due to acute illness and pre-existing disease, effects of anesthetic agents, and positive pressure ventilation. As you could see, the hypoxemic reserve is different in critically ill adults, obese patients, or critically ill children compared to normal adults, with reserve and a time to oxygen desaturation during hypoxemia is quite low. Hypotension is due to cardiovascular effects of positive pressure ventilation predominantly, with decreased preload, obviously worse with pre-existing hypovolemia, with increased right ventricular afterload, worse with pulmonary hypertension, hypoxemia, and acidosis, and autopip in patients with chronic obstructive pulmonary disease or asthma. Other reason is vasodilatation and cardiac suppression due to sedative induction drugs, and worsening acidosis due to apnea, worse if pre-existing acidosis, and hypoxemia per se. The effects of positive pressure ventilation or cardiac function are depicted in this figure, where there are different effects on right ventricle and left ventricle. Transition to positive pressure ventilation to the RV decreases the preload and increases the afterload, impairing the RV function, while usually it has somewhat beneficial effect on LV dysfunction with decreased preload and afterload. There was a recent consensus recommendation from Society of Airway Management with a group of experts who went through modified Delphi consensus to come up with recommendations in the absence of studies. For prevention of hypoxemia, it is clear that pre-oxygenation should be performed, if possible, either using high-flow oxygen or non-invasive ventilation or bag valve mask ventilation with PEEP valve for at least 3 minutes or 8 vital capacity breaths. There was a high agreement for all of these statements. If the patient has significant shunt physiology or reduced FRC, such as pregnancy, obesity, ARDS, pre-oxygenation should be performed with PEEP using non-invasive ventilation or bag valve mask with a PEEP valve. Apneic oxygenation can be performed with either standard nasal cannula at 15 liters per minute or even better with high-flow nasal oxygen systems at 40 to 70 liters per minute. Ramped positioning with a head up should be performed when possible to improve grade of view, improve maintenance of oxygenation, and reduce aspiration risk. As you could see here, apneic oxygenation is effective with an ambient oxygen fraction of 100% oxygen, where you could significantly increase the time to the saturation during apnea from 40 to almost 200 seconds. High-flow nasal cannula is preferred method, but alternatively, nasal cannula at 15 liters per minute during laryngoscopy can be used. Awake intubation to maintain spontaneous respiration should be considered for patients with refractory hypoxemia prior to intubation. Another newer recommendation is with regards to so-called delayed sequence intubation, which can be performed using small doses of ketamine to avoid apnea from dissociative dose and being ready, obviously, for emergent intubation, but delayed sequences to allow the time for hypoxemia correction, bag valve mask, or non-invasive pre-oxygenation while preventing aspiration or placing the NG tube to prevent inspiration. In certain circumstances, inhaled pulmonary vasodilators can be considered to improve VQ mismatch before intubation, particularly in patients with severe hypoxemia and right ventricular failure. Briefly about delayed sequence intubation, the indication is patients who is agitated or otherwise intolerant of pre-oxygenations with either bag valve mask or non-invasive ventilation or nasal prongs. And another procedure, for example, is required, but the patient would not tolerate it, such as placement of nasogastric tube in a setting of ileus or GI hemorrhage. Ketamine is used at the doses of 0.2 to 1 milligram per kilogram, and administering neuromuscular blocking agents after the pre-oxygenation and or NG2 placement. With regards to prevention of hypotension, it is of utmost importance that the patient have intravenous access sufficient for rapid fluid administration before intubation, 2 peripheral IVs, preferably larger bore. If not, consider intraosseous access. Patients should be screened for high risk of hemodynamic collapse with intubation, and those who have a high shock index, so systolic blood pressure over heart rate more than 0.7, are at increased risks, even in the absence of hypotension. Fluid responsive and fluid tolerant patients, usually evaluated by cardiac ultrasound, point of care ultrasound, should be fluid resuscitated prior to intubation or at least during the intubation. And vasopressin infusion should be started before intubation in patients that are not volume responsive or fluid tolerant, or really in everyone at high risk. Bolus dose vasopressors should be available and used to maintain systemic pressure. Diluted epinephrine should be considered as a vasopressor of choice for bolus doses in patients with depressed myocardial function, again evaluated by point of care ultrasound. Hemodynamically neutral induction agents should be used, such as etomidate or ketamine, rather than propofol, and always with careful and possibly reduced dosing. These are pros and cons for different hypnotics and neuromuscular blockades. We usually recommend against propofol in patients who are at risk of severe hemodynamic instability. With regards to metabolic acidosis, those who are in severe metabolic acidosis are at high risk of decompensation due to volume repletion and inadequate alveolar ventilation during apnea and during sedation post-intubation. So patients with high minute ventilation requirements should be considered for awake intubation to maintain spontaneous respiration, such as with severe salicylate poisoning, for example. Also consider a spontaneous breathing mode after intubation in patients with very high minute volume requirements, and also try in a control mode, try to match the minute volume that was used by the patient prior to intubation. And one should consider sodium bicarbonate for prevention of worsening acidosis during apnea at the time of induction. That's a conditional recommendation. With regards to increased intracranial pressure, it is important to maintain eucapnia, so normal PaCO2 during, before, and after intubation. Hemodynamically neutral induction agents should be used. Patients should be positioned at 30% upright when possible, and post-intubation management should include limiting PEEP to promote cerebral venous drainage, so no more than 10 of PEEP if possible. Patients with right ventricular failure are at extreme risk of hemodynamic decompensation after intubation. Patients should always be screened with the point-of-care ultrasound before intubation. When one identifies RV dysfunction, patients should be evaluated for systolic function and fluid tolerance. Small boluses of fluid can be considered if patient is fluid tolerant, but if you don't have the ultrasound capability, that could also be dangerous. Pre-intubation diuresis can also be considered in patients with a severe RV volume overload. Mean arterial pressure has to be augmented to maintain coronary perfusion pressure, and in patients with chronic pulmonary arterial hypertension, possibly a higher mean arterial pressure should be targeted to keep mean arterial pressure above mean pulmonary artery pressures. RV afterload can be reduced with inhaled, preferably, or intravenous pulmonary vasodilators. So if the patient was on pulmonary vasodilators intravenously, they should be continued through intubation, but if in a patient, otherwise the inhaled pulmonary vasodilators, such as inhaled nitric oxide, should be used to minimize risk of hemodynamic collapse. The right ventricle collapse during intubation is depicted here in this picture, where the increased RV afterload rapidly leads to spiral of positive feedback loops with reduced RV contractility, worsening coronary perfusion, cardiogenic shock, and death. Pre-intubation ECMO cannulation can be considered if available in patients with severe RV failure-induced shock prior to intubation. And cannulas should be made and even before the intubation and induction agents. Hypercapnia should definitely be avoided, as well as hypoxemia, and ventilation strategy after intubation should include low mean airway pressure and some amount of PEEP to avoid atelectasis, but not too high of a PEEP. As you could see here, that both atelectasis and overdistension would increase pulmonary vascular resistance and make the right ventricular function worse. In this case, some amount of PEEP is needed, but not excessive. We have reviewed our practice of patients with severe pulmonary hypertension who underwent endotracheal intubation, as there was quite a significant mortality of almost 40% of these patients, and patients who had worse pH, worse PaCO2, and worse PO2 were more likely to die after the intubation in a setting of pre-existing pulmonary hypertension. With regards to preventing gastric aspiration, again, point-of-care ultrasound is important to evaluate if there is a large amount of fluid in the stomach that needs to be drained with a placement of gastric tube prior to intubation. Society of Critical Care Medicine clinical practice guidelines recently also made some recommendations very similar to preventing of hypoxemia with pre-oxygenation with non-invasive ventilation and or high-flow nasal cannula with an upright position and with delayed sequence intubation. There were no, however, specific recommendations for fluid and vasopressors, and they did recommend nasogastric tube decompression in patients at high risk of regurgitation of gastric content. I like this French guideline for the safe intubation practice to prevent both anatomic consequences of anatomic and physiologic difficulty airway. With the 2 operators, fluid loading if needed, and early introduction of vasopressors, preparation of long-term sedation prior to intubation, upright position, 3 minutes of non-invasive ventilation or high-flow nasal cannula, followed by apnoic oxygenation in patients with high risk, use of first video laryngoscope and rapid sequence induction with etomidate or ketamine rather than propofol, and the ventilation in a case with a bag and valve and mask if the risk of desaturation is higher than the risk of aspiration during apnea. Capnography, obviously, to check the correct placement of the tube, vasopressors to maintain the blood pressure range, early long-term sedation, low airway pressure ventilation with lung protective ventilation as a start, followed by a short recruitment maneuver and checking the cuff pressure. Thank you very much for this opportunity. I hope this talk will be useful for your practice. Bye-bye.